This presentation is on the practical application of blood flow restriction training. It is given to the team of Stanford Healthcare Physical Therapists on January 15th, 2020. It's also the first of our elective courses for our orthopedic residency this year. So the primary objective of this presentation is to positively influence the practice of the individual therapists that attend today's lecture. Additionally, I hope that this positively influences the individual patients that they see. On a broader scale, I hope that this as a whole improves the quality of care that we give as a department, which there influences the 600 patient visits per week. Additionally, helps to influence the collective mind and foster collaboration amongst therapists. On a tertiary level, I hope to improve Stanford Healthcare physical therapy on the whole. This says not only from a social aspect of the outside looking in and a networking as far as how other healthcare providers and healthcare systems, patients, communities, etc. view Stanford Healthcare physical therapy, but in the profession as a whole. I hope that we stand as a marker to raise our standards, and thus others will be influenced and inspired to do the same. So today's information really focuses predominantly on the practical application of blood flow restriction training. There are several other lectures that have been sent out previously that look at the mechanisms, the safety, as well as the overall current evidence as of December 2019. And I can again share those resources should you need the links to those videos. But today is all about how to actually apply it within the clinical setting. Okay, so there's 5 objectives of this presentation. The first is to describe an algorithmic decision-making process to identify appropriate patients who are appropriate for blood flow restriction training, or BFR. Utilize evidence screening process to stratify patients' risk of adverse responses with BFR. Perform a limb occlusion pressure using an ultrasound Doppler for the upper and lower extremity and go through the procedures of each. Determine the optimal occlusion and exercise parameters and specifications for BFR, and verbalize the evidence and the criterion-based clinical progression that is otherwise recommended with BFR. Okay, so let's start with the screening algorithm. Within this, we'll identify the appropriate patient, discuss evidence-based screening processes, and describe the limb occlusion pressures. Okay, so this is an algorithm that's presented by Scott et al. In 2014 that essentially takes a patient and determines whether it's indicated that they perform blood flow restriction training as part of their treatment. The first is, are there any contraindications? If there are, then refer to the physician. If their physician says that they're okay for BFR, then you can continue with the algorithm. Is the individual mobile? If no, perform passive BFR, meaning just cyclic ischemic preconditioning, as they call it, where the individual's blood is occluded without active exercise. Can they tolerate low load resistance training? If no, then do aerobic training with BFR. If they can, then do low load BFR. And if they can tolerate high loads, do BFR plus traditional high load resistance training. So relatively good model. However, I do believe that there's a couple of areas for improvement that I'd like to highlight. The first is that the generic description of does this individual have contraindications for BFR, though critically important for safety and application, I do believe that there's a better workflow than just asking the generic question of contraindications and checking this for every patient, and I'll propose that. Additionally, it states here that MDs may not be, that will have to make the decision if there's the presence of a contraindication. Given how novel BFR training is within the healthcare system, it's possible that MDs may not be familiar with BFR, evidence-based practice, contraindications, or precautions. I know this has certainly been my experience when I've reached out to physicians to consult with their perspectives on whether a patient was indicated or not, or if I had any concerns. Additionally, applying moderate BFR alone to the limbs. This assumes that all patients who are not mobile or who are immobile and aren't contraindicated for BFR should receive BFR. And I would make the argument that this is indeed not the case, and that there's further screening that needs to be done. And again, I'll propose this workflow and the screening process in full. Additionally, there's only one decision point at which point the individual can be referred to traditional resistance training. Not traditional resistance training, but plan of care as usual without BFR. And so I would say that the algorithm is inherently biased because of that hinging decision point of whether the physician believes it's indicated for them to do BFR or not. Okay, so this is the proposed alternative algorithm that is a little bit more in depth and a little bit more specific. Though it looks quite daunting on the surface, I'd like to kind of simplify it for you by labeling a couple things. So there's similarities between this and the Scott et al. In 2014. Can the patient benefit from BFR? Are there any contraindications using the EMR and subjective screening questionnaire? You have to consent the patient, you have to consent the physician if indeed their precautions are in question and or the patient is post-operative. Active effusion and inflammation. If that's present, then you need to treat and control that. Otherwise, you perform the limb occlusion pressure and then triage which type or form of exercise of BFR would be most appropriate. So really, it comes down to 8 steps. And we'll go through each of these in turn. So can this patient's outcome be accelerated or improved by utilizing BFR? So would the other way to ask this question, would the following physiological adaptations aid in your patient's rehabilitation? So you have local adaptations. Can they benefit from muscle strength, muscle hypertrophy, satellite and progenitor cell activation for tissue healing and repair? This goes for soft tissue, not only contractile but also non-contractile. Blood flow and nutrient delivery to the area of injury. Bone healing, growth, and or positive remodeling if they're at risk for bone mineral density changes. If they have a healing fracture, would they benefit from positive or accelerated bone growth? Systemic adaptations. Would the patient benefit from cardiovascular conditioning? Would they benefit from VEGF, or is a growth factor for the formation of new blood vessels to provide additional nutrients and oxygen to the area? Soft tissue repair. Would they benefit from tendon repair and remodeling on a systemic level due to the hormonal effects of BFR? We're going to go into the assumption, just sticking with the algorithm, that yes, in this case they will be, but again, if in fact your patient would not necessarily benefit from any of those local or systemic effects, then you would continue with traditional rehab in the plan of care. Okay, let's say that they actually were going to benefit from one of those local and or systemic effects. Then the next point in the decision tree process. So you're going to screen the medical chart, and you're also going to look at a subjective screening tool that's going to actually have a point system associated with it. So the point system is essentially 0 to 5, and the lower they are on the scale, the more indicated they are for blood flow restriction training, the less risk that they have. So I'd like to show you a proposed workflow on how you can easily and succinctly do this within the clinic. So if the medical chart demonstrates contraindications, then you would continue with the traditional rehab. If they score a 4 or higher, then you would also continue with traditional. So here's the proposed workflow in the EPIC system of how you can succinctly do this within a 5-minute time frame. So you're going to click on your sidebar and you're going to open up the edit notes section. This is not where you typically type, I recognize that, but you're going to type in the dot phrase .mjbfr screening, and you can click it there. I've already shared this with the team. All right, and then if we open this up, I'll kind of show you what it all entails. So if I scroll up to the top, you can see that I have the initial blood flow restriction screening questionnaire and contraindications, and I've broken it down by circulatory system, metabolic system, and other system. And so you would just go through their problem list and their past medical history. The form is already predetermined to say no on all the contraindications. All you need to do is identify the ones that otherwise would be present. Here, this is a subjective screening questionnaire, and I'm highlighting it for you. And I've put in verbiage that would be otherwise consistent from a legality standpoint, saying that all the yeses and all the nos that are checked are indicated by the patient. And this simply double checks your contraindications, and from a liability standpoint, ensures that you are covered and that you're conducting both a thorough medical chart review as well as a subjective review in case the medical record is otherwise not indicated. Here you can see hypertension, diabetes, hyperlipidemia, and obesity qualifiers, and I'll show you that up there in the questionnaire. There's a small asterisk and a symbol that if in question, for instance, it says severe diabetes, or if the patient says, yes, I have diabetes, then you would then go down to the labs and look at stratify their indications, precautions, and contraindications based off their fasting blood glucose. So I invite you to try out the dot phrase. Again, it is critically important. It will only work in the edit note section. It won't work if you try and do the dot phrase into the actual subject, objective, or assessment areas as you traditionally do in your workflow. Okay, so say you've gone through that process, and we're going to go under the assumption that they have a score of less than 4. Okay, so if they have a score of 3 or 4, you're going to have precautions that BFR can only be performed in the lower extremities. If they have a score of less than 3, then you move on to patient consent without any precautions for the lower extremity. So here you need to discuss with your patient the risk and the benefits of BFR. This is where it comes into play with that you are well versed in understanding and succinctly describing what BFR is, the benefits that it has, the risks, and being able to answer the patient's questions. So this is the scenario that you can expect to have. So your patient presents with a lower extremity injury, and you're thinking, based off the medical chart screening and the subjective questions that you've asked them, that it's indicated for BFR. So you're like, I know what can help you. It can accelerate your healing, your muscle growth, and your hypertrophy in a shorter time frame and using less weight and resistance and less training volume than traditional. Let's restrict the blood and exercise your leg. And the typical response is like, WTF. So typically this blank stare is then followed by a series of redundant questions. What is BFR? Why would we do it? What is the benefit? Is it safe? What are the risks? My doctor didn't mention anything like that when he sent me to physical therapy. What type of exercises should I do with it? Will it hurt? What can I expect? Can I do it at home? Can I just use any cuff or band? How often do I need to do it? And how long do I need to do it? Not only in a given session, but across time. And so this is where the preparation material that I had sent out becomes critically important for you to be able to succinctly answer each of these questions. We're not going to go into depth with them now, but know that those are likely the questions and the response that you may get from your patients when you propose that they would be indicated and would benefit from this form of training. So moving on, is the patient post-op or are there relative contraindications in question? So obviously, if the patient says, no, I'm not interested, or they don't give their consent, then you're going to continue with traditional rehab. If they are post-op or have relative contraindications, notice the different phrasing here between this and what Scott et al. Proposes, saying whether if there's contraindications that you check with the doctor here. If there's contraindications, then you're not going to do BFR. If there's relative contraindications, at that time point you can consider discussing your concerns with a physician and describing the physiological issues or concerns that you have that may help to inform their decision and their clearance. Okay, and then so based off what the MD says or what their decision is, so if they're not post-op or if there's relative contraindication, or there are no relative contraindications that are in question, then you would proceed. If the doctor says, yes, okay, based off the discussion that you have with him or her, is there active inflammation or joint effusion in the occluded limb? If yes, hold off from BFR and control the inflammation. Now, controlling inflammation is something that we do on a regular basis as part of your traditional orthopedic practice. Some of the strategies that I've implemented and that the research supports are compression stockings, pneumatic sequential compression devices, NMES, active exercise, hydrostatic pressure using the pool, using pharmacological management and joint aspirations essentially on the less conservative side of medical management for joint effusions. Okay, so if the joint is inflamed, then control it. Then you ask the question, obviously, again, is the joint effusion and inflammation controlled? If no, then continue to treat it. If yes, and or there is no active inflammation to begin with, then you're going to perform the limb occlusion pressure assessment. Okay, and so this has a series of events that are very similar in the upper and lower extremity. We'll start with the upper extremity. So there's 8 steps outlined here, and we'll go through this in the lab session to follow. So you have the description, and then you also have the images to help guide you. Have the patient lie in supine, place the cuff around the upper thigh, palpate the dorsalis pedis, and mark with a dry erase marker that location. You're going to place the ultrasound gel over the marked artery, turn on the Doppler, ensure that the volume is up loud, and put the Doppler head on the artery. You will then gradually pump up the pressure until the cuff the audible sound of the pulse disappears, and at which point you would document the amount of pressure in millimeters of mercury that it took to completely occlude the limb. Okay, and then for the upper extremity, it's very similar. I'll say it's often easier to palpate and often easier to get a succinct reading with the Doppler as far as getting the audible pulsing of the artery. Okay, so then if the patient's indicated, right, and they don't have an effusion and the doctor says it's okay, and you perform the limb occlusion pressure, then can this patient tolerate active exercise? If no, then initiate the ischemic preconditioning BFR protocol. And we'll go through this. Can the patient tolerate resisted exercise? If no, then you're going to do the light or low load cycling and walking that was proposed previously by the Scott protocol. If yes, then you're going to initiate low load BFR resistance training. Can this patient tolerate greater than 70% 1RM or traditional resistance training? If no, then stick with your low load. If yes, then I also advocate for a combination of high load resistance training and low load BFR for the hormonal effects and augmenting the effects of traditional resistance training. So in conclusion, the decisions that you're left with, or the actions that you're left with, is again stratifying the risk, or stratifying the risk of the individual determining whether it's indicated for them to perform BFR, have them perform traditional resistance training if they're not indicated, and then determining whether they should be doing passive exercise, low load or low intensity, aerobic, low load resistance training, or low load resistance training in the presence of BFR plus high load resistance training. Okay, the algorithm looks like this. Can they benefit? If yes, are there contraindications? Ask them if they're okay with it. If there's relative contraindications, then check with the physician, explain your physiological rationale so that they can make an informed decision. Active effusion and inflammation, if yes, then treat it. If not, limb occlusion pressure, and then finally determine whether at which level of the phase progression of BFR they should initiate. Okay, so the optimal prescription and progression, and we'll talk about the occlusion parameters, the exercise parameters, and the progression criterion. Okay, so this is a relatively busy slide. I'm going to orient you to it. So the first column is the occlusion variable. You're looking at cuff application, cuff type, and the occlusion pressure. The recommended parameters for each of these variables. So application, you're going to choose the most proximal portion of the upper or lower extremity. You can do unilateral or bilateral BFR. Never do upper and lower simultaneously for obvious reasons. There's insufficient blood flow centrally. Thus, this can lead to additional exceedingly high hemodynamics as well as lack of blood flow to vital organs in the brain. Cuff type. Advocate for best practices using an FDA-approved Level 1 pneumonic tourniquet system. There's 2 on the market. That's the Owens Recovery Science Delphi unit and the Smart Tools cuffs that we do have in our clinic. As of 1/1/2020, there's been only 2 FDA-approved cuffs within the United States. So then the width of the cuff also matters. Both of the FDA-approved cuff marketers take this into account. The occlusion pressure. So the upper extremities, you should be using 80% of your limb occlusion pressure. The upper extremities, 50%. Ischemic preconditioning uses the highest amount of pressure at 80 to 100% of limb occlusion. Keep in mind that 60% in the lower extremities and 40% in the upper extremities have shown to have comparable adaptations to that of the 80% limb occlusion pressure and the 50% limb occlusion pressure in the lower and upper extremities respectively. That being said, the 80 and the 50 have been touted because that ensures that during the rest periods and during the inter-rep states that the patient sustains that adequate high pressure that is needed. Okay, so exercise specifications. So once again, the table is a little busy and I'll orient you. So the first column is variable. The second is the passive exercise, aerobic exercise, and resistance exercise parameters respectively. So type of exercise, passive exercise, you're not doing any exercise. Aerobic, you're either doing walk-in stationary bike or UBE. Resistance training, you can do open kinetic chain, closed kinetic chain, or a combination of both. The frequency for passive exercise, you want to be doing this twice a day, which is not obviously feasible at times unless the patient invests in their own cuffs, which I've had several patients do that to date. Additionally, you want to be doing it 5 to 6 days per week. Aerobic exercise and resistance exercise for clinical population, it's appropriate 2 to 3 times per week. For athletic and performance populations, higher frequency has also been shown to be effective at 3 to 4 times per week. Exercise intensity, the passive is not so much. There's no intensity there, so there's no exercise. For the aerobic exercise, 40 to 60% heart rate max. Resistance, 20 to 40% 1 rep max. Volume, so 5 sets of 5 minutes with 3-minute rests for the passive. 5 to 30 minutes of aerobic, low load aerobic training. And then for the resistance, traditionally it's higher volume as you're trying to stress the metabolic system, with 4 sets being traditional, 30, 15, 15, 15, and you can do up to 5 exercises. You'll be deflating in between each set, in between each exercise. The rest for the resistance is 30 seconds between sets and 60 seconds between exercises with that deflate in there, as I mentioned. The duration, you can do it, the passive for 2 to 6 weeks, active exercise 6 to 10 or longer, depending if you transition into a hybrid model between traditional and low load resistance training, or low load BFR and traditional resistance training. The tempo, this is pretty important. So with the resistance training in particular, you want to be doing a 2-1-2, meaning that for example, if you're going into an eccentric squat, it's going to be 2 seconds down, 1 second at the bottom, 2 seconds up. This equates to approximately 12 reps per minute. You can set a metronome on your phone, is what I typically do. If you set it at 48 beats per second, then they'll wait for a tick at the top and a tick at the bottom of their movements. Okay, so then what I do want to revisit in considering the exercise specifications is the 4 options that you have for exercise. And what I like to do is propose and transition these 4 options into phases. So here you would start with the pre-ischemic conditioning BFR protocol. Then you would go to the low load resistance walking, and then you would or cycling, the aerobic training, and then you would initiate the low load resistance training once the patient was otherwise indicated. And so somewhat separate, and it's not quite clear from the Scott model, is that it's essentially you're bucketing patients. Well, I like to think of it more as a continuum for these patients, progressing their function and what they can actually tolerate with their BFR training, assuming that they are indicated. And so you can see that the blue arrows there kind of go back and forth between the low load cycling or aerobic training and the low load resistance training, suggesting that you can be doing these both simultaneously within a single session, or at least within the same time frame within rehabilitation progression. And then finally, then you have the combined low load resistance training and the high load traditional resistance training. Okay, and so here's how the phases would break down. And then I'd like to break these each down further so you have a clear identified pathway and progression through. So let's start with phase 1. So it would look like this. There'd be 4 components, or 4 areas of in phase progression. So the first would be ischemic preconditioning. So this is for your patient that can't that is somewhat hesitant and sensitive to pressures and doesn't like to exercise with too much high intensity. Then this may otherwise be a good way to get their body used to the occlusion and the pressure. So essentially you just occlude their blood and have them lie in supine. This is there is effectiveness in this. It is shown to preserve muscle mass in the lower extremities, particularly in the hiatus of exercise. So if they can't otherwise exercise, or if they're working on something passively, then this may be a means by which you can get their body exposed to the pressures. Then you would combine this with NMES on the subsequent session. And then on sessions to come, then you have them do isometric, where they're just contracting for instance, their quadricep or their bicep or what have you, depending on the muscle and area of injury. And then finally, within this phase, you'd be progressing them to NMES and the IPC, or the ischemic preconditioning. Again, they're not necessarily doing anything active or dynamic, I should say. They are doing the isometric contraction, and this preps them for the phase 2. So in addition to the parameters that I've already provided, I also wanted to give you these resources for your reference that kind of go through the goals of each of the different components here, as far as the passive ischemic preconditioning, as well as the passive with Russian stim. The Russian stim, or the NMES, in combination with the isometrics, are shown and would be exactly the same. So these are simply for your reference. So then I also want to set up criteria so that you're not left guessing when the patient is ready to progress into phase 2. So they should have no adverse reactions to phase 1. They should have completed all sets of a given exercise or given regimen. Perhaps you don't start them at the beginning. Perhaps they just want to kind of try it out, but they've previously done NMES and they're used to that. So perhaps you start them with the IPC with the NMES and the isometric contraction. So again, I'm providing you a stepwise continuum, but you can start the patient wherever within the continuum that you otherwise deem it appropriate. Their RPE or their Omni RPE score is less than 7 out of 10, and for those of you who are familiar, great. For those of you who would like a refresher, I'll go over it. And then able to actively exercise as well. Okay, phase 2. So you have the aerobic and you have the resistance training, both at low intensities or low load. So once again, I've provided example parameters, goals, and specifications for each in addition to the previous references that I gave you in the table previously shown. So note here that with the low load resistance training, you want them to maximally volitionally contract their muscles, not only the muscle in question, say you're trying to strengthen the hamstring or the quadricep, but you want to try and get a co-contraction and have them volitionally contract their muscle. The example that I give is like you can make a fist, that's all fine and good, but then you can make a fist and you can squeeze that fist. It's the same concept here. They can go through the sit to stand or the squat movement without fully engaging or fully contracting their muscles, but that's what you're going for. Obviously, symptom modulation within. Reinflate the cuffs after set number 2. Sometimes they will lose some inflation, and you want to ensure that you keep them above that 50%, or excuse me, that 60% threshold in the lower extremities and that 40% threshold of limb occlusion pressure in the upper extremities. And you want to have full available range of motion with the movements. Okay, so another way that you can kind of scheme this is, as I mentioned previously or alluded to, is that you can start to combine them. So here's a progression that I often use is we'll start with open kinetic chain exercises or uni-joint exercises. Then you do that with NMES. Then you add one variable of having them do a stationary cycle for 5 to 10 minutes. And then over subsequent times, and given their tolerance to this and able to complete all sets and reps, and their RPE is relatively stationary or stable or perhaps even declining, then you can progress accordingly with combining OKC, NMES, closed kinetic chain, and aerobic training in a single session. And then finally doing all components at the end there. Okay. The progression criteria into phase 3, no adverse reactions, complete all sets and reps of the given sub phase that they're on. Their Omni scores are less than 7 out of 10, and they're able to tolerate greater than 70% 1RM resistance training, because that is what is to come in phase 3. And phase 3. So we have BFR low intensity cardiovascular conditioning. We have traditional cardiovascular conditioning, we have BFR low load resistance training, and we have traditional resistance training. And so I've already given you the parameters for both the low intensity cardiovascular training with BFR as well as the low load resistance training. The traditional cardiovascular conditioning and the traditional resistance training I'm not going to go through just due to the scope and the nature of this presentation. However, the great resources are the National Strength and Conditioning Association, your previous continuing education courses, and NASM also puts out some additional information. That's the National American Sports Medicine Association. Okay, so exercise progressions. So here's the rationale for incorporating high load resistance training in combination with BFR. So this was a systematic review and meta-analysis that was shown in the preliminary preparatory material that was sent out, and so this may be familiar to most of you. So when you compare high load resistance training to low load BFR for strength adaptations muscle strength and hypertrophy, it consistently shows that high load resistance training is superior. However, I believe that the evidence is somewhat lacking behind in the sense that the early preliminary studies demonstrate, and I believe in the fact that BFR does augment the adaptations of high load resistance training, thus the rationale for combining them together. And so if they can handle heavy, then give them heavy. And I also want to put in an anecdotal or personal perspective is that what I've seen in my career thus far is the fact that inevitably often the joint becomes the limiting factor later in life. And that being said, the joint issues, the musculoskeletal and orthopedic issues, then manifest themselves into systemic and non-communicable diseases due to the lifestyle changes that then take place. This then transpires into increased morbidity and thus eventually mortality. And thus, if we're trying to keep our patients safe, healthy, strong, and as mobile as possible, as long as possible, while preserving the joint health, then I do believe that this is potentially a way in which we can progress the longevity. And thus, if you're going to be loading your joints with heavy weights repeatedly over time, which is healthy and necessary, but if you can get those same benefits while also taxing the metabolic system and the cardiovascular system, I'm a believer that this may be a potential solution or a potential alternative that may, again, preserve the longevity while maintaining strength. Okay, so I've alluded to the Omni RPE scale. So this is essentially a validated RPE scale that's been utilized with both like traditional resistance training using dumbbells, and there's also been a validated score using a TheraBand. So you no longer do you have to be guessing whether it's indicated to go from one TheraBand to the next. So it's it's been validated, reliable across clinicians, within clinicians, that the RPE scale, how it correlates to essentially their 1 rep max. And you can also, so you can ask them in a couple different manners. You can ask them to score their RPE on the scale. You can give them essentially verbal explanations, right? They're like, I don't really know what an 8 out of 10 is or whether I'm there. It's where you can typically end a set when you're feeling strong, meaning that you could probably give an additional 2 repetitions. That would be an 8. Where you're, or for example, they say, I'm not really sure whether I'm at a 10 or not, and I'm like, okay, can you do another repetition? They're like, no. I said, perfect. You're right where you need to be. Close to that 9.5 to 10. Okay, so this is now converting their score, their RPE score, to the recommended amount that you want to increase their resistance. Now, with traditional resistance training, meaning like isotonic, or isotonic meaning dumbbell, not your accommodating resistance, such as the TheraBand, which is maybe a little bit more challenging. And we'll talk about this in the next slide. But this gives you specific guidance and rationale for how much you're increasing the individual's weight, or the recommendation that you're giving them based off their RPE. Additionally, what has also been shown is that the RPE for a given number of repetitions has also been determined to look at the actual training goals and adaptations that you want to induce. So this looks like a relatively straightforward scale, and perhaps maybe you've seen these before, but I actually encourage you to spend some time with it. So let's go through an example, for instance, differentiating between strength and hypertrophy, which is commonly a point of discussion. So say your patient is doing 10 repetitions, and they say that I'm at an 8 out of 10. on the RPE scale? What if they're doing 6 repetitions or 4 repetitions and they're at an 8 out of 10? Now, you know in both instances that they're not quite ready for progression, but you're not really sure what adaptations that you're getting. This scale, by finding the coordinates of their repetitions performed and their RPE, helps to guide you as to what the training adaptations likely are going to be. And so I thought that it was potentially helpful and a beneficial chart for your reference as well. Additionally, what has also been shown is that auto-regulation within resistance training progression is superior to that of a systematic or linear progression. What this means is that if you empower the patient and inform them how to progress their weight, that they are more effective. It's more effective for them to do so than for you to give them a linear progression where you're progressing on a projected scale. This obviously goes under the assumption that they take your advice, they understand it, and they're able to practically implement it. But it's known that by the 2x2 rule, and I consistently utilize this with the patients that I deem it appropriate with. So if the patient exceeds a target rep by 2 repetitions on the final set on 2 consecutive exercise bouts, that means if they're doing bench press and their target rep is 10 and they get 12, and they did their bench on Monday and they do their bench on Friday, and in both instances they've used the same weight and they've exceeded their target rep range and gotten 12 repetitions, then you want to be increasing. And how much should they be increasing? Well, so the NSCA gives us further guidance on that as well. So depending on the upper body, lower body, and the size of the muscle, then you can give an estimated range as far as like how much additional weight they should be progressing per each. So I understand that these are not really specific to blood flow restriction training, but it's critically important that we understand that despite the fact that we're not loading our patients to their 70% rep max or more, that we are still using the progressive resistance training methods. And that being said, sometimes with this patient population, particularly within the clinical setting, we'll be utilizing TheraBand versus your traditional isotonic dumbbell. And so this scale also is here for your reference, giving the pounds in force at different lengths of the TheraBand stretch, which can help you to stratify the percentage increase that you're giving and providing to your patients. Finally, if we're trying to keep our patients within our 20 to 40% one rep max, which again may change as they continue to get stronger, then it would be ideal for us to at least attempt to predict what their one rep max is. So this slide is specifically for your reference to do just that. You can see how many repetitions they performed, what percentage of their one rep max that was, and then you can also use a multiplication factor there in the third column. Okay, other nuance about BFRs that you want to keep in mind, the fact that over time that it will have a linear decline that's parallel to that of high intensity resistance training. So this again was in the prelim information, but it will take individuals about 6 sessions to drop about 1 to 2 points on the perceived exertion scale. And so they often will ask, will this get easier, or will this get harder, or what have you? And this gives you guidance in saying that it will be initially like high intensity resistance training or high intensity training that you may or may not be used to, and that over time, though, we know that it's just going to get easier for you and will continually progress as needed. Okay, and here are the recommended outcome measures that you can take: circumference, thickness of the limb segment, the force production, using biofeedback and or surface EMG to determine the muscle, the change in the activation of the muscle, if it was undergoing arthrogenic or neurologic inhibition. Serial imaging can be done where you're looking at x-rays, if you're looking at x-rays for bone remodeling, or you're looking at MRI for muscle adaptations. Patient-specific functional performance measures, be it a single leg squat, gait, tug, lateral step down, depending on the appropriateness of the patient, and then obviously their functional outcome measures. Okay, so let's talk briefly about the limitations of BFR. So there's 5 of them that I've identified that are most concerning. The first is that it's not superior to heavy load resistance training when it comes to the strength gains as well as the hypertrophy gains as previously identified. The use of non-FDA regulated cuffs is occurring. Poor prescription practices of therapists. Effects of chronic BFR utilization is unknown, just given the fact that it's only been approximately 50 years that it's been in Japan, and only about, I would say about 12 years or so since it's been commercially available in the United States, ever since 2008. And then also the methodology of some of the study design. So there's risk of bias in. So we'll step through a couple of these limitations. So this is what you'll get if you type in blood flow restriction training. And so this is likely what your patients are exposed to, all of which of these are non-FDA approved. Again, there's only 2 that are on the market. The Delphi unit that automates the process of taking the limb occlusion pressure and also accommodates the pressure during the muscle contraction and relaxation, and the smart cuffs that we utilize in our clinic. So additionally, besides for the cuff appropriateness, they also look at it's also been considered the prescription of BFR, and so they looked across 250 different clinics, and which included strength and conditioning coaches, sports scientists, physiotherapists, researchers, and doctors, and factors determining the BFR cuff pressure. So quite often you can see that patient brachial pressure was utilized for 19%. However, the literature values were predominantly used in over 43%. So this means that therapists and providers are looking at the literature, determining the pressures to be used based off that, meaning like they saw in this one study that they used 180 millimeters of mercury, so I'm going to use 180 millimeters of mercury on my patient, which you can see the flawed logic there and why that may put the patient at a risk for an adverse event or increased excessive pressures, or it may not provide the adequate benefit of the resistance training in BFR if that's well below the threshold that they should otherwise. Inherently, when you're looking at the prescription in duration of time, so the therapists are between 20 and 30 minutes and upwards of 50 minutes of occlusion. Though those training sessions can take this long, it's highly recommended that there actually be deflations and breaks within the exercises, and so it wasn't otherwise indicated here whether that was the case, but excessive duration of time of occlusion has been linked for a further increase in side effects and adverse effects. Okay, and finally, the last 2 limitations. The effects of chronic BFR utilization are unknown, as previously mentioned, and the methodology of the study design. So in the last 3 years, there's been 17 systematic reviews on the subject of BFR, looking at different patient populations. And consistently, one of the things that has been discussed within the author's conclusions, within the discussion section, has been the methodology in the study design, which is, not too surprising with a new modality and not really fully grasping the proper methodology when designing a study. I can understand that, but this is a point that we need to address with higher methodological design studies in the future. All right, summary and conclusion. So we started this conversation with the algorithm, and I'll show it again here. Can they benefit from BFR? If yes, contraindications. Patient says okay, doctor says okay, there's no inflammation, or you're going to control that, and then you're going to perform the limb occlusion pressure and conduct the stratification as to what type of training would be most effective. Exercise specifications. This is again reference material. It will be in the lab handout. So the passive exercise is phase 1. The aerobic and resistance training is phase 2 and also incorporates phase 3, but with the higher intensity and the higher loads that were applied for both aerobic and resistance exercise respectively. Okay, then if we check in with the objectives, so the algorithmic decision-making process was described. You're able to utilize a screening process, which you can use the dot phrase that was otherwise proposed. And then the limb occlusion pressure described the procedures, the optimal occlusion and exercise parameters were included, and then we also talked about the evidence-based and criterion-based clinical progression of BFR using the 3 phases. Okay, what comments, questions, concerns, feedback, please feel free to put in the discussion section, and I look forward to the lab session to come. All right, and then